And good afternoon, everybody. My name is Mark Pratt. I am the Senior Vice President of Public Affairs at CAQH. Thanks very much for joining today's webinar on tackling administrative burdens in Ohio's Medicaid program. I suppose we might consider this webinar as a bit of counter-programming against all of the post-election analysis underway today. I'd like to start, of course, by thanking Kelly O'Reilly and her terrific team at OAHP for facilitating this webinar. We very much appreciate our partnership with the association and commend OAHP for its leadership on behalf of the health plan community in Ohio. I'd also like to thank my CAQH colleagues whom you'll be hearing from today, and I'll introduce them shortly. First, a few housekeeping items. Please note that this webinar is being recorded. Registrants will receive a link to the recording in the days following the webinar. During the presentation, all participant phones will be muted. However, we do encourage you to submit questions throughout the webinar using the chat box to the right of the screen, and we will get to as many as we can. And of course, also encourage you to follow up with us after the webinar. A quick word about CAQH. We are a nonprofit collaborative dedicated to administrative simplification in healthcare. We work with stakeholders across the healthcare ecosystem to transform healthcare business processes, as outlined in this slide, through deploying shared utilities, developing national operating rules, and conducting research and engaging stakeholders. On today's webinar, we will cover three topics: centralizing provider credentialing, reducing Medicaid waste, and improving prior authorization. As you know, each of these issues were addressed by the Ohio Department of Medicaid as part of its ongoing work to transform its already very strong Medicaid managed care program. We certainly commend the administration for undertaking this important initiative and would like to offer CAQH as a resource to the agency, to OAHP, the MCOs, and the provider and stakeholder communities as this important work continues. As you know, Medicaid is a crucial safety net program, and the importance of strengthening it has only been magnified in the midst of the pandemic. For our part at CAQH, we offer our experience and expertise on reducing administrative costs and burdens in states throughout the country and in Washington, D.C. I'm happy to say that here in the Buckeye State, we enjoy a very strong and long-standing presence. Today, for example, more than 80,000 healthcare providers in Ohio submit their demographic information to CAQH, and some 118 or so healthcare organizations, including all 5 of the current Medicaid MCOs, participate in and benefit from our programs. So again, thank you to OAHP. We look forward not only to today's discussion, but also our ongoing collaboration in this important work. I'm now delighted to introduce our presenters. Their brief bios are listed on this slide. Taryn Theograj will speak on centralizing and streamlining the credentialing process. Morgan Tackett will discuss reducing waste through improved coordination of benefits processes. And Aaron Weber will talk about improving and streamlining prior authorization processes. So a lot to cover in a short amount of time, and I will now turn things over to TJ.
Thanks, Mark. Good afternoon, everybody, and thank you for joining us today. I thought it might be helpful just to start by briefly level setting what I mean by credentialing before I go into talking about centralized credentialing. So, any credentialers that we have here in the audience will no doubt recognize the Verify and Comply handbook that I've got here on the slide. But what you can see over here is the definition according to that guide. The text is taken directly from the handbook. Now, organizations credential practitioners not just to comply with state and federal regulations or with accreditation requirements, but also because they've come to realize that it's another tool that they can use to help assure the care and safety of their patients. So ends up being quite an important process for a health plan. When we at CAQH talk about credentialing, this little slide just lays out the way we think about it. There are these 4 broad steps that we have in mind. Collecting provider self-reported information, typically within a credentialing application, then taking that provider reported information and verifying some of it against an appropriate primary source. For example, the provider may say that they're licensed to practice medicine in Ohio, but are they really? So we need to just make sure and check that that information is in fact accurate against the appropriate primary source. Once information about the provider has been collected and verified, then using that information to make a committee decision about whether or not to accept that provider into the network. And then, of course, once that provider has been credentialed and is in network, performing sanctions or license, performing ongoing monitoring to make sure that we catch any sanctions or license actions that may occur before the provider is re-credentialed in 3 years. Now, in a health plan, all of these activities typically happen side by side with contracting. One of the things that CAQH did several years ago was perform some research to look into the effort and time spent on these various activities. And what we found was that there are many inefficiencies, particularly if the process is performed manually. So we saw that a huge amount of effort goes just into getting a complete application from the provider. There's often a lot of back and forth. It's often found that information is unclear or sometimes completely missing, and that necessitates following up with the provider. With primary source verification, again, a lot of plans, this is a manual process, and so there are inefficiencies there. There's a need to acquire data from certain primary sources that charge for them, so there are costs there. So there's a lot of inefficiencies that creep into the system. Now, on this next slide, you'll see that these labor-intensive administrative activities that I talked about, they're bad enough when you consider a one-to-one relationship between health plan and provider. And we looked at some of those efficiencies in the last slide, but these are really exacerbated when you consider that providers contract with many health plans. And so there are these huge redundancies that creep into the system. Individual health plans are often reaching out duplicatively to the same provider. You've got situations where different plans are paying for the same data to verify the same information for the same provider. Now, if a given plan looks only at its own volume, it can be hard to make the case for investment in automation and technology. And what that means is that many health plans are sometimes still conducting this process manually, which means that it takes more time, it's more prone to error, and so on. Now, I've been talking about some of the plan side impacts, but really this impacts providers as well. Providers will have different health plans reaching out for the same clarification for the same provider, and it takes resources on the provider side to answer some of these questions. We've talked to provider organizations, and many of them have dedicated individuals whose only job it is to respond to these health plan queries that come in and handle enrollment with the health plan. So all of this collectively, it adds up to increased time to network participation and the ability to see patients and file claims. So it's got revenue implications as well for the providers. So a lot of inefficiencies, a lot of problems for both health plan and provider side. So let's talk a little bit about how centralized credentialing can help. Before we do that, I wanted to just show what we mean when we talk about centralized credentialing. There's a few different possible flavors of what a centralized credentialing solution might look like. I'm just going to describe one here to help really paint the picture. So imagine that instead of a provider filling out separate individual credentialing applications, they could utilize a single web-based portal into which they put their demographic and professional information. And it's a kind of a quote-unquote smart application, which means that they only see questions that are relevant to them based on the type of provider they are, what their specialty is, etc. And there can be data validations built into the system that help ensure cleaner data. What this means to the data coming to the health plan is there is a reduced need for clarification and correction by the plan. Now, that centralization of data collection can also be extended to primary source verification. So rather than each health plan verifying the same information for a provider, it's something that can be done just once in a centralized fashion. And critically, by the provider having entered all this data into one single place, that information can be made available to all the health plans that subscribe to that service. Now, what I'm showing here and what I've been describing, that's not just pie in the sky, it's something that already exists. CAQH ProView is the credentialing application that gathers information from providers. It's that centralized portal that I described. And CAQH also has a CVO service that complements ProView by performing primary source verification. So what are the implications of that? What are the benefits? The obvious benefit, of course, is the do once, use many approach that I described, where you're just collecting the data once, verifying it once, and that is sent to multiple plans. But there are other benefits of this system as well, this setup, that helps both plans and providers. So first of all, because providers just have to go into one place and put their information there, it's very speedy, and all the plans that subscribe to that can receive the most complete, up-to-date information for that provider. The system can generate that information in an electronic format. So it's not just a paper application for example, that the provider is filling out. It's information that the plan can receive in bulk in an electric format that they can then automatically feed into their own systems. And then there are automated reminders that go out to providers, ensuring that the information is kept fresh. We well know that information changes over time as providers leave and join different organizations, update their qualifications, etc. And so these reminders ensure that providers come in on an ongoing basis and keep their information up to date. And that up-to-date information can be received by the health plan. The system that CAQH has set up, ProView, is free for providers. It's pretty simplified. There's a 3-step process for the provider to come in and register, create their profile, upload their documents, and then attest to their information. And that generates for the provider just this single application that they can use to send to many health plans. And if the provider, in fact, happens to be practicing in different states, the information that is gathered just once can be used to populate the state applications irrespective of their different format. So all of this collectively taken together sums up to a very significant reduction in credentialing costs for the industry as a whole. It helps to eliminate redundant labor that's spent in performing primary source verification. If organizations today are performing primary source verification independently, they are each paying for some of these data access fees. By having it be centralized, those fees can be spread across multiple organizations. So there's an opportunity to reduce costs there as well. On this next slide, just a few stats for the state of Ohio. What you see here is the fact that not only does the solution exist, it's also got pretty widespread adoption within Ohio. A huge portion of the Ohio practitioner population already has a ProView profile, and the overlap shows that the benefit I described earlier is in fact real. Providers can fill out their application in just one place, and it's available to multiple health plans. So just to wrap up, credentialing performed one-on-one by individual health plans can be time-consuming, inefficient, and have a lot of redundancy, but it doesn't have to be that way. Centralized credentialing can solve those problems and has a lot to offer.
Thank you, TJ. I'm going to pause here for one moment and just ask the audience if you have any questions related to centralized scheduling, please post them in chat. Otherwise, we will hand off to Morgan.
Hey, great.
Questions. Yep. Go right ahead, Morgan. I apologize. Go right ahead.
Okay, no worries. Thanks, everybody. Glad to be with you today. On the topic of coordination of benefits, just switching gears a little bit here, I think we can all agree that challenges with current industry coordination of benefits processes are numerous. First of all, it's difficult to share information across payers, and what information is shared is usually done retrospectively and manually, which drives up the cost to the payer. And second, every health plan has a different way of doing things. And so when those manual inquiries do happen, they generally take longer to process as a result of there being no real common language that health plans speak regarding coordination of benefits. And then third, the data that is shared may be of differential quality, especially if that data is not current, which is often the case when COB data is only updated once a year from a patient survey, or if it's gleaned from an inbound claim that contains other coverage information. And CAQH recognizes that the absence of this complete and timely information set about all the coverage that a health plan member carries can be a driver of costs through errors, delays, associated rework that occurs when a payment's made to the wrong payer or in the wrong order to a healthcare provider. And inefficiencies in COB research, investigation, and resolution span the life cycle of the patient encounter that you see here. If providers don't have the correct information on their patient's coverages, claims can then be filed to the wrong payer or in the wrong order, which eventually results in the need to re-adjudicate the claim, request recoveries and refunds from providers and patients, putting that patient in the middle of the healthcare transaction, and manage the communications that trade back and forth between the provider and the payer, or the payer or the provider and their patient or your member. And so many of these expenses can be avoided through the transparent and secure sharing of common patient coverage information. So next slide, again, a few of those challenges we've talked about. COB data is volatile, it's prone to change over time. We have an anecdote that I like to quote here about a member that we saw starting the year out with having coverage through a health plan. In the first quarter, they left that job, and for a while they were jobless, and so they did not have any COB with their husband's coverage. Then they got another job, so there was another COB event with another payer. They stayed in that job for 6 months and then went back to their old job. And so they ended the year with the same coverage that they'd had at the beginning of the year. And so it looked, if you're looking at information on COB just once a year or in some sort of an episodic way, you'd expect that same overlap to have been in place all year, but actually there was a break in coverage and 3 distinct COB overlap events during that calendar year. So data is very volatile, very prone to change. And we know that Medicaid data can be even more dynamic as members move in and out of coverage, especially in these times of COVID, when we're seeing the shift of folks from being covered by commercial coverage over to other coverage. Our solution provides a weekly insight into the volatility and the movability of that data. And we've seen more than expected overlaps of commercial and Medicaid coverages than we would have originally expected when we were looking at the build of this solution 7 years ago. And so we think Medicaid plans have the easiest path to research, resolve, and load COB records for accurate claims processing. Here, I just wanted to show you a little bit that we see in our solution database around the distribution of membership in the state of Ohio and how that has changed over time. And you'll see that we've seen a shrink in coverages associated to commercial group coverage and a corresponding increase in membership associated with Medicaid MCO plans as we've seen the impacts of COVID in the marketplace. And hopefully this will resonate with you as you look at that information in your own data set there. And certainly we know that COVID has changed many aspects of traditional COB and payment integrity program operations within health plans. First of all, the balance of activity between recovery and prevention has been disrupted, and more focus is now on prevention as recovery processes have been redirected or even disallowed in certain states in which we work. As I mentioned, we've seen a shifting membership as job losses and associated healthcare coverage losses evolve over time. And we've seen that migration of coverage from that group insured to that individual exchange or Medicaid coverage. And we've also seen in our data set in general, not so much in the state of Ohio, growth in Medicare Advantage membership, as we've seen furloughed employees move over to either early retirement or some type of cost savings pursuit by joining a managed product as opposed to a fully insured product. So just some changes that we see there in the state of Ohio. Our solution at CAQH to work with COB data is called COB Smart, and COB Smart is a large national database that health plans voluntarily contribute membership data to, and CAQH matches members who belong to multiple health plans and then determines which of those plans are primarily liable to pay the claim for the member. And then this data is securely reported back to the health plan and the provider so that the appropriate claims processing decisions can be made. And then we also make this data available to health plan participants through a secure portal-based utility. And on the next slide, we're proud of the fact and the impact that we've had on our customers and our industry over the 7 years that we've been working with COB data. We've assisted health plans to identify overpaid claims amounts, which leads to the potential to recover those overpaid claims. We provided health plans with more primary source information, and when I say primary source, I'm talking direct from other participating health plans about their own membership, that allows them to reevaluate and realign their use of third-party vendors and have less dependence on those third-party vendors to manage COB events. We've assisted health plans in paying claims more correctly once accurate and timely information is loaded into the health plan membership system. We've assisted health plans in reducing the costs of doing business by changing the staff allocation to COB operational tasks and increasing the total data opportunity for COB data within the plan, streamlining the process that leads to correct member load and membership data update of COB information. And ultimately, the health plan providers and members benefit from having this, this opportunity for claims to be processed correctly the first time, instead of having the downstream rework, delay, and inefficiency associated to COB activity. So on this next slide, when we're talking with our customer base, potential customers, folks looking at making a change in COB operations, we encourage them when considering a COB solution to look at the following data considerations. First of all, whose data are you using? Is it redacted, or is it from a data warehouse? Is it aged, or is it coming directly from a payer source that manages and controls that member in a membership database? How current is it? Is it real time? Is it, again, coming from a repository that may be updated every week, every month, every quarter? How does the data interface with your current data? How quickly can you take information that you find about your member having other coverage and upload your membership system so that forward-going claims can be paid and processed correctly? How easy is the data to use? How does it incorporate and auto load into your backend system? How helpful or hurtful, either one, is the data to your providers and to your members? Is it accurate? Is it trustworthy? Is it timely? Does it empower you to make the right decisions when you're processing claims and servicing your members? And how costly is the data to acquire? So on this next slide, this is a schematic of our end-to-end process, and I would encourage you not to read the numbers across, but to follow the numbering schema through the workflow here. So what we do is we work with participating plans to share information into a large database of coverage on a weekly basis using a standard file layout containing 65 data elements on individual members who are loaded into the database. CAQH collects that information in the database, and we perform the matching process. We apply NAIC primacy rules to identify overlaps. And increasingly, I'll talk about this a little bit later, we're going back when we identify overlaps and revalidating with the health plan. Not only is the member The member that is being matched is the same member in one plan as in the other. But we're also looking to make sure that the coverage that's being reported as an overlap is currently active in both payers' data sets. And that's really, really important, because the presence of an overlap is beneficial, but it's more beneficial when you know that it is currently active, that it's trustworthy, that it can be auto-loaded to your system, updating the member record, and used in back-end operations to play claims, process members, manage members, and perform operational functions. So every week we're getting data from payers, every week we're sending data back to payers, we're maintaining the repository of data that can be accessed a number of different ways by the participating health plans. And the end-to-end process helps health plans who participate to analyze shared data, confirm current active coverage status of members and shared overlaps, and produce reporting that allows health plans to consume data with the least amount of manual intervention and review as possible. A component of our data sharing with health plans is portal-based. So we have a portal that provides easy access to staff across the payer enterprise for reviewing and using shared COB data. Some top features of our COB portal include inquiry lookup for COB records history, a data overrides feature which allows shared data to be augmented and commented by both health plans that share a member. So if there is a piece of information that is a legal letter or a court decree, that document can be attached to the record that's maintained at that member overlap within the COB portal for health plans to have easy access to share information that today may be traded via fax or secure email or other functions that health plans use to share information. We have a new workflow feature which allows all of our participating health plans to link to each other and again avoid the use of that secure email. I don't know about you, but we work with 43 health plans at CAQH, and maintaining 43 distinct secure sign-ins to secure portals to trade information is a challenge to maintain. So now we have a capability through this single portal solution for health plans to ask each other questions about shared coverage, send and receive information attaching to a COB record. And since we launched this workflow solution back in the end of the summer, we've facilitated nearly 3,000 conversations payer to payer without that payer having to pick up the phone, call the other plan, and figure out how to resolve the COB case between those two health plans. And also through the portal, we're able to maintain a list of subject matter experts within health plans. So if you're working with another health plan that's also using CAQH data, you're able to find out who is your contact who manages the Medicaid MCO business within that health plan, so that you can get easy access to zero in on the right contact within that health plan that's doing the same type of work that you're doing, and able to seek resolution to that case. I mentioned validation. So we've gotten some information back from our users of our validation service. The way that we're validating in that workflow that I described a few slides ago is we're using X12 transactions. So when we're pulling the record into our COB database and we're identifying that overlap and we're reporting it back to the member, we're using that standard X12 HIPAA 270 inquiry back to the health plan to render a 271 response back to CAQH that lets us know the coverage status of that member record. Is it currently still active? Yes or no? And if it's been rendered inactive, because we know the data changes over time, we are able to apply those term dates to the database and communicate those term dates and the close of a coverage span as a COB overlap to both payers using that X12 transaction data. And so what the impact of having that validated record to this large national health plan that uses our solution is that they've been able to increase their auto load of COB data on a week-over-week basis by setting OI flags in their member system by about 20%. And this number is still growing over time as they're more fully incorporating the data validation information into their systems. They're reducing their cost to validate insurance through using clearinghouses, manual phone calls, or other vendors to validate records. They've been able to increase their prospective savings by getting member records updated and avoiding the incorrect payment of claims downstream by having the member record right-sized in their membership system. And they've been able to increase productivity because they're able to use the workflow tool, because they're able to update more records more quickly. The manual effort to maintain their COB program has been significantly reduced. And a little shout out on our validation accuracy using those X12 transactions. We're getting reports from our health plans that about 99.5% of the time when we're confirming that an overlap is active, or if it's terminated and there's a term date applied to that overlap, we're accurate to that degree of precision, which we're very proud of. And just in using COB data in general, we think it's very interesting that we see the ROI savings at a health plan level tracking very closely whether they're working with only exclusively commercial business or if they have a Medicaid component. The ROI is nearly the same across the payer. And again, those savings include reduction in medical expense from correct claims initiative, reducing administrative costs associated with rework and reprocessing of claims, reducing third-party vendor dependency by giving the health plan more authority and ownership of their member data and their COB data, and certainly improving or reducing abrasion and improving the member and provider experience by paying providers more quickly, more correctly, and taking the member out of the middle of resolving any downstream claim issues that are associated to COB cases. So I'll wrap up on this next slide just by summarizing what we think the significant impacts to COB processing are that we've worked with health plans in the industry to achieve over the last 7 years. Reading from the bottom, we have this coverage database that is composed of information that's primary source driven, direct from health plans. It's predictable in terms of the cost to use the data. There's no variable fee. There's a very fixed fee associated to accessing this data that's associated directly to the number of members that are associated to a health plan. We're looking to, again, move COB operations from a retrospective perspective to a prospective approach by getting the member record updated and claims processed more quickly the first time. And again, increasing the data stewardship within the health plan of reducing that vendor dependency, increasing ownership of data, and eliminating the costs associated to very expensive claims recoveries in arrears. So I'll stop there and see if there are any questions.
We have no questions in the chat. Thank you very much, Morgan.
So I'll turn it over to Erin now.
Thanks, Morgan, and thanks everyone for joining us today. I'm going to switch gears a bit and talk about another topic that I know is very top of mind for this group, and that is improving prior authorization. Mark mentioned in the beginning of the presentation that CAQH Core is an initiative of CAQH. We are a participant-driven initiative with about 120 organizations representing a diverse group of healthcare stakeholders, health plans, providers, vendors, clearinghouses, associations, government organizations that come together to develop operating rules or business rules to support the exchange of healthcare information between stakeholders. And in particular, to date, we have focused largely on administrative information related to the healthcare claim and billing processes. We see our role not only to develop operating rules, but also to drive adoption of those rules through a certification program, measure the impact of those rules through pilots and other initiatives, and educate and inform the industry through industry webinars and presentations. We were designated by the Secretary of Health and Human Services as the National Operating Rule Author through HIPAA to develop rules for the HIPAA-covered administrative transactions. On the next slide, we highlight some of those HIPAA administrative transactions, and this data comes from the CAQH Index report, which tracks industry adoption of electronic healthcare transactions. You may know that under HIPAA, health plans are required to support certain X12 transactions for the exchange of healthcare billing and claim payment information. It is not always how health plans and providers exchange this information, but it is one mechanism that must be supported by health plans. We track that information through data submitted to us by health plans and providers around the country to see how the industry is progressing in moving towards a more fully electronic system. The categories of the way we look at these transactions are fully manual. So if we're using the example of prior authorization, fully manual would be phone calls and fax machines, to partially automated, and we look at that as the health plan portal, where it may be automated for the health plans, but providers are still having to manually log into multiple websites with differing requirements and information to be submitted for a prior authorization. And then fully automated, which is the adoption of the HIPAA transaction for prior authorization, and that is the X12278 transaction. As you can look through this data, you see there's a couple points where the electronic adoption is a little low, both for prior authorization and attachments. There is not a HIPAA standard for attachments yet in the industry. So much of that information, and that's like clinical and documentation that needs to be sent to support a claim payment or a prior authorization. Much of that is still done manually. And I'm going to talk a little bit in a minute about why we think some of these prior authorization numbers are a little bit low. Next slide. You may well be aware that the industry has really had heightened awareness of some of the challenges around prior authorization over the last couple of years. We have seen a lot of action in both the public sector and within the industry. At HHS, we've seen both ONC and CMS focus on the need to reduce the burden around prior authorization. We have several committees, federal advisory committees collaborating on prior authorization to make recommendations to HHS, as well as some pilot work going on at CMS to automate the requirement lookup for prior authorization. Congress has a bill that they've been working on for some time to address the use of prior authorization under Medicare Advantage, as well as there have been more than 50 pieces of legislation across the states over the past couple of years as well. The industry is also having a lot of discussion. We've seen from both provider and health plan associations some consensus statements, some guiding principles coming out to help direct the industry as they look to make some improvements to the prior authorization process, as well as, in addition to CAQH Core, some industry-wide coalition efforts, including work through the eHealth Initiative and the Da Vinci Project, which is looking at using the HL7 FHIR API to help improve the exchange of prior authorization information. Next slide. I mentioned earlier, we really categorize prior authorization information exchange in 3 different ways: the manual, the partially, and then optimized. When I say fully electronic prior authorization, it is very much recognized that there may be some components of the prior authorization process that may always require some level of human interaction, but certainly the process can be automated in a way greater than it is currently. Next slide. So the CAQH Core participating organizations, many of which are from Ohio, in fact, from a provider perspective, both the Cleveland Clinic and Ohio Health, as well as the Ohio Hospital Association, have been engaged in our work. On the plan side, AltCare, Medical Mutual, Molina, CareSource, and SummaCare have all engaged with us in one way or the other with our operating rules. These groups have come together to really think about what are the true challenges to automating prior authorization. And from a core perspective, we really look at automating and improving processes and not necessarily the health plan policies related to prior authorization. So operating rules would never specify what services would require prior authorization, but they may specify how that information is exchanged between a health plan and provider. There's a lot of challenges to automating the prior authorization process that don't really exist for some of these other transactions. The first, and I often find this the most surprising one, is that there's just a lack of industry awareness around the availability of that X12-278 transaction to exchange prior authorization information. And many providers, in fact, don't know that it's federally mandated. In some ways, there has been limited availability of this transaction because of the lack of detail and consistency in how information is shared on that transaction. And that's some of what I'll talk in a minute about what the operating rules are trying to help address. There has been limited availability of vendor products that support that transaction as well. A recent CAQH index found that only 12% of vendors supported electronic prior authorization, and that number is much higher for the other electronic transactions. Varying state requirements for manual interventions and response times. Our research found that there are states that allow a 15-day turnaround time on a prior authorization determination. Other states have a 2-day turnaround timeline. So that makes it very difficult to standardize processes and exchange mechanisms between the plans and providers. I mentioned earlier too, there is no federally mandated attachment standard. So creating automation and building adjudication systems is very difficult when that additional information can't necessarily be sent in a standard way. Also, there's lack of integration between clinical and administrative systems, and this is a little bit more unique to the prior authorization use case because that clinical information is often needed to justify a prior authorization. So when those systems can't speak to each other, it makes it much more difficult to build automation. What the CAQH core participating organizations came together to develop operating rules specifically focused on improving the use of the X12-278 transaction, that HIPAA mandated transaction, with the thinking that most health plans are supporting some level of the transactions, given that is required under HIPAA. What could be done to those transactions to make them more valuable to the industry? So our work groups came together and developed a set of rules. I have to say it was one of our more contentious and challenging rule development processes because the stakeholders really have varied interests, but the group came together and really made some great compromises and progress to develop a set of rules that I'll speak to in a minute. Next slide. Earlier this year, the CAQH core board did propose 3 operating rules to the HHS secretary for national adoption under HIPAA related to prior authorization. The rules address pressing need to improve the automation and timeliness of prior authorization. They promote uniform security and interoperability requirements, as well as supporting future convergence of administrative and clinical data. In August, a federal advisory committee to the secretary held a hearing on this rule set, and that group will finalize its recommendations to the HHS secretary in about 2 weeks at its next meeting. So stay tuned as to what's to come there. Next slide. I'm not going to go into the technical details of these 3 operating rules that were proposed for federal mandate, but just to highlight that the first one is a data content rule related to that 278 transaction. And it requires a lot of optional data elements in the 278 that ensure that providers and health plans are getting the exact and very specific information they need to process a prior authorization, understand next steps, and understand the reason for certain decisions. All of our operating rules have an infrastructure rule, which relates to how that transaction is exchanged. So in particular, for the prior authorization, this rule contains requirements around when a health plan must request additional documentation from a provider once a prior authorization has been submitted, and that is 2 business days. And then how long a health plan has to submit a final determination once it has received all of the information it needs to make a final determination. That timeline is also 2 business days. And then there is a connectivity rule as well to support how that transaction is sent to and from the provider and health plan. I'm not going to go into all the detail on this slide, but just to point out, this is sort of our day in the life of a prior authorization slide. You can imagine the typical scenario where a provider may pick up a phone or log into a health plan portal and submit a request. And even if they start off electronically going through a portal, many provider authorizations drop to manual when a provider may not get a response as quickly as they were hoping, and they'll pick up the phone and call, and the rest of the process will occur via the phone. With these new operating rules, it's much more likely that the prior authorization process remains electronic. So similar to a claim and the claim adjudication process. So the provider can submit a prior authorization, the health plan acknowledges it has received it. The rules contain some name normalization and particular code requirements that help the plan understand exactly what the provider is asking. The health plan then determines whether or not they need additional information. They pend the request and have a certain amount of time, again, to send that data request to the provider. The provider then returns that clinical documentation as requested, and the health plan has 2 business days to make a determination. Next slide, please. So we have 2 case studies that I wanted to highlight here for you, one from a health plan and one from a provider, about how the use of the X12-278 transaction coupled with these operating rules that I mentioned have improved business processes for both a plan and a provider. You can see at Harvard Pilgrim Healthcare in Massachusetts, they have been using this transaction for quite a while now. And with some of the automation provided by the rules, they have been able to reduce or reallocate FTEs supporting referral and authorizations. And 85% of their requests via the 278 are responded to in real time. So it is certainly beneficial to think about automation. Cleveland Clinic similarly recently implemented a tool to help automate their prior authorization processes, and they're seeing significant increases in staff satisfaction as well as time saved from automating key components of the workflow. Next slide. Building on a solid foundation. So this is not the end of our work on prior authorization. We will continue to serve as a resource to you and to the industry based on the knowledge that we have gained so far. We do have some white paper information on our website if you're interested in learning more. Right now, our participating organizations are in the process of developing prior authorization attachments operating rules. I mentioned that was sort of the missing piece still to the automation of the prior authorization process, and we hope to have those rules early next year. We also continue to do pilots and ROI assessment with some of our partner organizations to ensure that the rules that are being developed have a strong impact on the industry. And organizations are beginning to become certified in these prior authorization and referral operating rules to demonstrate their commitment to improving and automating this process. And you can see some of our early adopters on this slide, including a state Medicaid from Texas. So with that, I just want to encourage you to feel free to reach out to our team. We have spent a lot of time talking to our industry partners about the challenges and opportunities within prior authorization and look forward to working with you over the next year or so to develop even more rules. With that, I'll turn it back to the team.
Thank you, Erin. And to the CAQH team, we have no questions in the chat. So attendees, if you have questions, please enter them in the question area or chat. Mark, if you could close out, and if we have time, I have a few questions that will draw out some insight if time permitting. So I'll hand to you, Mark.
Sure, and I'll close where I started to thank OHP for this opportunity to chat with you all about some of the issues that you all are grappling with and that the state Medicaid agency is undertaking as part of its reimagination, if you will, of the Medicaid managed care program. We hope that you have found this helpful and informative, and do want to offer ourselves as a resource on these and other administrative simplification topics as they arise in your state. So again, thank you for the opportunity. We look forward to continuing to be a resource to you.
Thank you, Mark. And presenters, if you'll humor me for a moment, what I'd like to do for the recording is just have a quick summary question for each section, starting with you, TJ. And pardon me, I'm going to flip through a bunch of slides. TJ, we shared metrics here, and I would like to know, first of all, what is the definition of a provider? And give me a sense of what these numbers will mean for Ohio and Ohio Medicaid.
Yeah, that's a great question. So when we talk about providers, really we're talking about individual practitioners over here, so not facilities, not organizations. So these are individuals that provide medical care. And really we're not just limiting ourselves here to physicians. This also includes non-physician providers such as nurse practitioners, physician assistants, etc. So that's what those numbers indicate over there. What this tells us really, I think, is when you look at the size of that number, what it tells us is that we've got pretty significant coverage of the practitioner population in Ohio within CAQH purview. So a significant portion of the medical practitioners in Ohio have already created CAQH purview profiles. They are entering their information in there, keeping it up to date, attesting to the information on a regular basis, which means that for health plans that are looking to credential those practitioners, the data is all there and it's all ready to go. The plans don't need to do additional follow-ups and chase work to get an attested application to credential the provider.
Thank you, TJ. Morgan and Aaron, I have the same question for both of you, starting with Morgan. Will you please tell us what is the most common question you receive from folks looking to improve their COB processes for their Medicaid program?
Would definitely be data-driven in nature. How can we create the best data set that we can control of our membership to contribute to the database for reliable, trustworthy results? And how can we give feedback to other participants about the opportunities for their data to improve? So again, one of the ways that we solve around that is that we have created this standard template of information, the 65 data elements that make up a member, but we've broken that down into terms of data elements that absolutely we must have in order to be able to create and maintain a COB record. Those are mandatory data elements. An additional set of elements that are recommended because they make a better COB record. They'll very likely prevent a phone call one payer to the other or an inquiry one payer to the other if they're included in the record. And then a set of data elements that are fully optional. They can be used primarily to help track the member back into the data within their system. So we're able to really help interpret that data standard and help our participating payers to understand what the benefits of including or excluding certain types of information in the COB record would be.
Thank you, Morgan. Final question for you, and same question for you, Aaron. What is the most common question you receive from folks in the Medicaid audience?
I think the most single question we get is, what's really going to move the market, or when should we really make some real changes to our processes? So as I mentioned, there are operating rules out there. There are folks using web portals. There are folks using phone. There are folks using the 278 transaction. And then there are organizations looking at newer technologies like FHIR and API. And so I think there's a question that commonly gets asked about which of these options should we be investing in and when? And my response to that is, there is a federally mandated HIPAA transaction now that organizations should be ready to use. and building on that work. And then the industry, I think, has a responsibility to make sure as we look towards newer technology like APIs, that the data content and the expectations surrounding the exchange of that information remains consistent regardless of standard, so that we can have a smooth transition when the industry is ready to take the next step in automation through those APIs.
Thank you, Erin. That is all we have. Mark, I will hand off to you for one final close comment, and we will end the session.
Thanks, Mike, and thanks to also to the CAQH team today for presenting on this webinar. And again, thanks to all of you for participating, and we look forward to continuing to work with you in the future. Have a great afternoon.